Hi everyone, and thank you for tuning in. I'm Dr. Zoe Williams, and you're listening to the Visionable podcast, the show that shares the views and perspectives of leading minds in healthcare. In each episode, I'll be interviewing leaders and experts from across the health and care landscape, discussing their thoughts on the most pressing topics in the sector right now and future innovations. Hi everyone, and thank you for tuning in. I'm Dr. Zoe Williams, and you're listening to the Visionable podcast, the show that shares the views and perspectives of leading minds in healthcare. In each episode, I will be interviewing leaders and experts from across the health and care landscape, discussing their thoughts on the most pressing topics in the sector right now and discussing future innovations. Today, we're talking about group consultations with Professor Fraser Birrell. Fraser is a consultant rheumatologist with the NHS up in Northumbria. He's an honorary Professor of Lifestyle Medicine and Innovation, and he's also Director of Science and Research for the British Society of Lifestyle Medicine. He was the first UK clinician to establish the group consultation clinical practice and now helps others to understand and share the benefits of this important tool for patients and staff. So thank you for joining me today, Fraser.
Thank you, Zoe.
So what I'd love to discuss first is some of the terminology. So we have group consultations, we have virtual consultations, and then we also have hybrid group consultations. So can you start us off with explaining what those different terms mean?
Of course, happy to. So the idea is that rather than seeing people one-to-one, a group consultation brings together several patients at the same time. So it might be 10 or 15 patients seeing one clinician. That creates time and space for care. If you do that virtually, it's a virtual group consultation. Any secure platform which allows you to deliver the care that way. Obviously, it's not exactly the same because you're remote, but you can see things, you can engage visually as well as verbally. And then, of course, the idea of a hybrid group consultation, either you could have a hybrid group where people attend in person as well as online on the platform,
right.
Or you can have a hybrid group consultation care pathway where, for example, in antenatal care, some of the groups could be in person and other groups might be virtual.
Okay, I'm with you. So, and do group consultations differ from shared medical appointments? Because I think that's another term that we sometimes hear.
Indeed, so group consultations is really the overarching term, and there are lots of different models.
Right.
But the shared medical appointment model is so widely used that a lot of people equate them. But for example, the shared medical appointments doesn't include all the really important evidence in antenatal care, or our own kind of inflammatory arthritis groups either. So it's important to recognise that there are some subtleties to this. And if you were doing some research and trying to find out what had been done in the area, it's important you understand all the different search terms you'd have to use to understand the literature.
Okay. And we know group consultations take place in general practice and in hospitals. You're a rheumatologist. So how long have you been seeing patients in this way in groups? You said 10 to 15 patients, which is quite a lot. How long have you been doing that for? How long would that type of an appointment last? And then I'd love to know a bit about what are the benefits? What are the benefits for patients, first and foremost, but also what are the benefits for staff?
So we started doing this back in 2008, and we did some pilots up in Berwick Infirmary, and we had groups initially of 8 and 12 patients, just to see whether we could get it working, because this is an idea that's been established for quite a while in America. We can talk about how long if you want afterwards, but that allowed us to collect some data, see that we could get it working, and because we had collected some data and we won an Innovation and Development Award from the British Society for Rheumatology, then that allowed us to then embed this in clinical practice and deliver routine care in groups on a monthly basis across an increasing part of Northumberland, including Alnwick and Berwick and in Morpeth and Wansbeck. So that's goes back a long way.
I think to a lot of us as clinicians and patients, the idea of group consultations is still relatively new, but how long have you been doing group consultations? And if you have 10 or 15 patients in a group, how long would that appointment be versus what an appointment would typically be?
We started looking at this back in 2008. And we did some pilot work with inflammatory arthritis patients at Berwick Infirmary, initially in groups of 8 and 12, to see whether we could get this working, because obviously it's had long-term success in America. It did work. The patients loved it. And based on the data that we collected, we won an Innovation in Development Award from the British Society of Rheumatology. And that then led to us embedding this in clinical practice and getting a service commission so that we could deliver this model of care on an ongoing basis, starting at Berwick and in Alnwick, and then it spread to other hospitals, including in Morpeth and
they're quite rural places.
Rural. Wandsbek General is more of a typical district general hospital, but this works. It doesn't matter which hospital you're in. Mm-hmm. What you need is a big room, staff who are passionate, and patients who want to try something new and willing to try something new. So we embedded this in practice, and over the years, the size of the groups got bigger. And at one stage we were concerned whether they were too big, because we were regularly getting more than between 15 and 20 patients attending a single session. And this is a 2-hour session.
Right.
And so we tried splitting it. So we would run more groups to keep them small. And what we found was that didn't work, because if you had a few people who didn't turn up, you ended up with a small group of maybe 6 or 8 rather than the 12. Fewer questions, fewer answers, and a less productive session.
Right.
So actually, after that experience, we decided to just go ahead with essentially the size of the room that we could use and the size that the patients were happy with. So over time, and we published our long-term data in 2021, in the last 2 years that we were doing this, the average group size was actually 23 patients in a 2-hour session. That compares to a 15-minute follow-up session. So that's almost a whole day's work delivered in 2 hours to the same quality or better.
Yeah. And I can understand that for patients who are willing to give this a go, they feel like, well, they've had 2 hours with a doctor, but not just that, they've also had 2 hours with other people who are going through what they're going through, who perhaps have questions that they hadn't even thought of, that they're benefiting from the answers from. So what are the sort of broad benefits of this style of consulting for patients, but also for the staff?
Really good point. And you know, the words you've used, that's almost exactly what the patients say. You know, I had the answers to questions I hadn't even thought to ask, and I benefited from all the peer support. The simplest way to think about the benefits is perhaps using the quintuple aim, which is a framework of thinking what great care looks like in any setting. And the 5 things are you getting the best outcomes? Mm-hmm. Are you getting satisfaction for the patients? Are you getting satisfaction for the clinicians, for the staff? So is there a joy of practicing that way? Is it cost effective? And finally, are you delivering good education, both education to the patients, but are you also delivering good education for trainees, including medical students and postgraduate education? So those are the 5 things that we look to. When we think about group consultations and virtual group consultations, it's probably one of the few models of care that can deliver all those things. Yeah. Because in the stressful times in the pandemic, we've had to change everything that we do. And a lot of it, we don't enjoy the new version, whereas actually this is one of the few things that everybody can really enjoy and benefit from.
And there are lots of reasons. I guess thinking about rheumatology patients, mobility can be an issue, getting to the hospital, parking can be expensive, you know, you might need somebody to come with you, it could take a whole day. But, you know, at Visionable, we often talk about some of the benefits of virtual consulting. Whilst there are some downsides as well, and it's not for everybody, there are a lot of benefits for some people. Did your patients feedback about that as well?
Absolutely, absolutely. So one of the things that's always frustrated me is, and you must have had this too, you've got the message that a patient didn't attend an appointment because they were too ill.
Yeah, yeah.
And they were in their greatest need, and yet because of the physical demands or social demands of getting to the hospital, they just didn't come. Yeah. And so they missed out. So to have that choice between attending a session in person or virtually, which is what you can do with a hybrid group, then you know, everybody wins. And unlike a normal appointment where if you don't turn up, you've kind of missed a slot and there's a gap and you've lost productivity. So what we call a failed to attend. And obviously the hospitals count this up and they say, well, gosh, we missed something there. Yeah. But actually, if everybody's arriving at the same time, it doesn't really matter whether you've got 20 or 25 people in the room.
Yeah.
And it doesn't matter whether
still
they're
effective,
virtually,
isn't
it's
it?
still effective.
Yeah, of
you haven't
course.
wasted any time, because they can always be invited to the next session if they're not available for that one.
And if usually one-to-one sessions are 15 minutes, but here you're seeing 20 patients plus in 2 hours, the patients feel like they're getting more out of it. Like you say, it's very cost effective. People can join virtually if that suits them better on the day. And what about the staff? What's the benefit to the staff?
Well,
do they like it? Do they say that they like it? I imagine students love it because that's brilliant for teaching.
They do. I mean, it doesn't suit everybody, but the people who like it really love it, because ultimately you're covering almost the whole of the rheumatology curriculum. So for new staff who don't know what you do, and it'd be the same in primary care. I imagine your receptionists very rarely are in the consultation room. So if you have a receptionist acting as the facilitator and they're directly involved in the care, they're not just handling the phone calls and being a gatekeeper, they're actually, a really productive element of the team. So it's all about recognizing that we can upskill our staff. The students, as you say, do love it, but people can really benefit from having the time and space. Unlike a normal clinic where there's always that pressure, the minute you're running behind and somebody's waiting for longer than you're seeing them, that's not a nice experience for anybody, for the patient or for the clinicians. This takes the pressure off because everybody's in the space from the beginning, and particularly when it's a virtual group, the space is the patient's own space, it's their own home.
Yeah.
So they do feel very comfortable, and there is a lot of benefits, kind of mental and social benefits to that.
So how does it actually work then? Because if a patient was coming in to see you in outpatients one-to-one, there might be some blood test results to go over, they might have had a scan, you might be explaining what is next, there may be sensitive issues. Do you still cover all of that in the group consultation? And if so, how do you get around the sort of confidentiality, that factor? Do people mind actually being given their results in front of a group of strangers?
No, it's a really important point. So before coming into the group, people have to buy into the concept of shared confidentiality.
Right.
So we do have a standard waiver, and everybody who's kind of present and observing has to respect that. There are certain issues that are so confidential that somebody would say, well, actually, I don't want to discuss this in the group. And so we've got a pathway where if people want to have a small discussion in a breakout room or arrange a one-to-one session afterwards, then that's possible. Mm-hmm. It's surprising how rare it is that happens.
Right, okay. Because you'd maybe think that people would take advantage of that, have the group consultation, but then try and have their one-to-one as well, but that doesn't happen.
It works the other way around. So for example, if you've got a patient who's really flaring, and I'm thinking back to a few particular instances where people had, massive physical as well as kind of social and emotional problems. Because the group is such a peer supportive environment, because they've had a chance to hear that other people are affected with the same problems they have and to understand and share their solutions, actually the conversation you have at the end is much shorter than it would have been. Right. So those flaring people who often in a one-to-one clinic, it doesn't fit in a 15-minute follow-up appointment. They often take half an hour, 45 minutes. The discussion you have at the end of a group session might only be 5 minutes, because actually, they've unpacked a little bit if they've gone out to have an injection with a nurse, for instance. We triangulate that when we're discussing at the end in the one-to-one, and it's all unpacked actually surprisingly efficiently.
And what involvement have patients had in the development of this type of consultation?
Well, they've been completely integral. So when we first piloted it, I did actually ask the patients, I recall, if they fancied doing what was effectively a shared medical appointment, which was a serial observed consultation. And my patients didn't like the idea of this. So we developed our own model. And that meant that they've been involved from the outset and had ownership. And because you're meeting with them regularly in the groups, the group becomes both a clinical care model, but it's also an engagement model. And when some paper comes up which is kind of challenging things which are dear to my patients, at one stage they even asked me to write a paper on their behalf to respond to that. So they've been involved in the outputs as well, and we've had people, contributing to the publications that we've done in this field as well of our patients. So they really do have ownership from the outset and have helped us securing grants to do this work as well. So it's a true partnership.
I think co-creation is so important, and when it's done well and it's done properly, it can just add so much value.
No, I agree. For example, the quintuple aim paper was actually written with a patient co-author as well.
Was it? So I'm certainly hearing more and more about group consultations, particularly I think as I have an interest also in lifestyle medicine, and we know that for many of the diseases that can be largely managed by lifestyle, then group consultations appear to work particularly well. I think my experience has been, I've seen it working incredibly well with type 2 diabetes, for example. But I think, people, especially during the pandemic, when people had to find new ways of working and virtual consultations became the norm, how widely recognised is this now? How many hospitals, how many GP practices, how many patients are engaging in consultations in this way?
Well, it's a really good question. Obviously, we did have to change a lot during the pandemic, and the data isn't actually very well joined up. The examples I would give you are that in Northwest London, they had developed a virtual group consultation model for diabetes called Fresh Start. That spread from initially 7 PCNs with about 300 patients involved to being across the whole of their CCG. So that was 360 practices.
Wow.
So we know that this can be embedded at scale. And another example, the NHS VGC, the Video Group Clinic Initiative, which essentially is another name for the same thing. They did sentinel work across 70 practices, and that was very successful, so it scaled up to cover 500 practices as well. So I don't have an exact figure to share, but it's certainly the order of thousands of GPs, and there's lots of hospitals who are delivering this too. It's not embedded as thoroughly as a treatment choice as we would like. So I guess what we're trying to do is try and embed this within the recovery plan, because a lot of people have waited a long time for care, and if it's possible for them to have a choice, do they want to wait to see somebody in a conventional way, or would they like to join more quickly and be seen through virtual group consultations or on a hybrid pathway?
Yeah,
and gives people more choices.
I think for patients, often that is their agenda, isn't it? They need to be seen quickly. I know here at Visionable we have a particular interest in brain injury, and we're doing a lot of work looking into rehabilitation when patients are discharged after a brain injury, whether it is a stroke or traumatic or otherwise. And that's when patients are really, really in need when they've immediately left hospital. It's very difficult for them actually to return to hospital. And we've been looking at group consultations as a model for that, but also, optimising virtual consultations. And there's so much new technology now that can deliver virtual, physios and being attached to various different devices so they can actually sort of in real time demonstrate exercises for patients. I think technology, group consultations, virtual consultations, they all support and help each other. And I do wonder what you think the future is for group consultations.
Well, the future is that this should become a routine choice for patients everywhere. It's not like there's a single healthcare system that actually delivers all the care that people need and want. And where we do see this embedded at scale, for example, at the Cleveland Clinic, they've done almost 100,000 group consultations, virtual group consultations now, across every service. We just see that people benefit because it's embedded at scale. It gives people different choices, shorter waiting lists, better quality care, better outcomes. So I see virtual and hybrid group consultations within care pathways, becoming a default, not just across the NHS, but more widely internationally. We've been looking particularly at low and middle income countries because obviously they have particular issues and have been impacted much more by the pandemic. The figures I've seen from the WHO suggest about a 4% impact for most high income countries and a 40% impact for the pandemic. So that means a lot of people simply don't get any care. And so, this is a model that's very good for addressing health inequality, whether that is in poor countries, where actually the care can be delivered remotely, if you've got clinicians in another country who want to contribute. So it could be, for instance, people could volunteer to help deliver care or to train people up. But then what you see is, even in settings like Nigeria, where group consultations for antenatal care have been looked at very thoroughly in a recent study, there was a massive effect where one of the key things is, do you get 4 antenatal care visits? And do you deliver in a proper maternity facility? Because that's obviously safest for mum and baby.
Yeah.
And Nigeria has, one of the highest, if not the highest, maternal mortality in the world.
Wow.
What we saw was massive effects, almost a doubling of in maternity unit delivery.
Wow.
And a massive increase to, I think it was 77% for people getting at least 4 antenatal visits.
Wow.
So the odds ratios were between 8 and 13.
Gosh.
So these were massive effects,
Yeah.
and this is an answer for providing more care at a better quality to more people.
And that's what's always so important when we're thinking about healthcare, isn't it? It's about equity, and it's about we will always make the biggest difference with it. We should be looking to make the biggest difference when we innovate to those who have the poorest healthcare and the poorest health outcomes primarily. And if you do that, then everybody benefits.
I agree, and obviously the northeast of England is not the richest part of the country, and at our webinar this week we had our public health midwife Carla and the nutrition feeding expert Claire were speaking about how they've embedded pregnancy education using a VGC model, and that's been effective in addressing health inequality because the poor people get better access to care. So we can achieve that here too.
So, I mean, it sounds wonderful, and I agree it is wonderful, which is one of the reasons I was so keen to cover this topic on the podcast. But what are the downsides then? There must be some downsides.
Well, there's downsides to everything. Not everybody loves it. Obviously, whenever you're thinking about technology, some people just don't like computers or even smartphones, although it's surprising how few people are in that category now. So, this has to be a choice. Some people really don't fancy the idea of being in a group, whether it's virtual or physical. We do have quite a lot of experience of people saying that they didn't fancy the idea of the group, but actually coming along anyway and seeing it. And then you would always give people like that the option to stay. And at the end, they often become the most passionate advocates. So I wouldn't say, particularly when you've got an innovation and not many people have experience of it, you can't really judge that in the same way. Mm-hmm. A lot of people don't like cutting edge innovation, whereas actually, I think as time goes on, that group is getting smaller and smaller. But if we look at our long-term data, when we were delivering 40% of the follow-up workload for Anik and Berwick through the groups, that just meant everything was easier. It took the pressure off the system. People who were flaring had the choice. Do they come to the group? Do they go to a normal clinic?
Yeah.
Our waiting lists were shorter than everywhere else in the trust. So it just has system benefits, and it doesn't need everybody to love it.
Yes.
It doesn't need everybody to do it. This should be a choice, but I think it should be a choice everywhere, and equally it should be a choice for the clinicians who deliver it, because you need the people looking after you to believe in what they're doing.
Yeah.
But I challenge any clinician who's not seen this model of care in action to attend. Obviously that's much easier now they're virtual. You don't even have to go there. And once you've seen it in action, challenge yourself to try something new.
I think that's the only way to really understand and experience and get your head around it, is to just simply sit on one of those calls and observe and see it for yourself, and then you really understand it. Fraser, thank you so much for giving up your time with us today and sharing your experience and insights with us. And thanks to Visionable as well for hosting this conversation. It's been really interesting to hear how powerful group consultations can be in enhancing the patient and clinician experience. A user-friendly platform like Visionable's Clinic solution makes it easy to invite patients and schedule virtual group consultations, which can be securely accessed from any device remotely, reducing missed appointments and efficiently using people's time. To find out more about Clinic and how it can benefit your consultations, please visit visionable.com/clinic. Throughout this podcast mini-series, we'll be discussing a whole range of pertinent issues facing healthcare with a new expert guest each time. So make sure you do subscribe to get notified of our next episode, and I'll see you next time.